Good morning, everyone. It's my honor to be here uh, to share my topic, left bundle branch area pacing for avoidance and the mitigation of heart failure. I'd like to illustrate my topic from the following three aspects. Firstly, let's see the current definition and the pacing features of left bundle branch area pacing. Let's see. This year, the HRS, APHRS, and LAHRS guidelines on CPP gives the definition of left bundle branch area pacing. The here the uh, left bundle branch area pacing include selective LBBP, non-selective LBBAP, and the deep septal pacing. Here, the deep septal pacing, that means left ventricular septal pacing. And also this year, the ERA clinical consensus statement on CSP, conduction system pacing, also gives the definition of LBBAP. Here, the LBBAP was defined as capture of the subendocardial area on the left side of the interventricular septum with or without conduction system pacing. It, it also include LBBP, LFP, and LVSP. Uh, 3 years ago, our team first compared the pacing parameters of LBBAP and HBB. In that study, we found the LBBAP have a high success rate and comparable with HBP. I think with our familiar with the more we practice more of LBBP, so the success rate of LBBAP increased now. And also we found the parameters of pacing parameters of LBBP is better than pacing parameters of HBP. This year, this study in heart rhythm, the Journal of Heart Rhythm also compared the pacing parameters between LBBAP and HBP, and they found the LBBAP have better pacing parameters than HBP. Our team first started the learning curve of LBBAP. And from this figure, we can see with the increasing of performance of LBBAP cases, we can see the procedure duration and the fluoroscopy time was similar, will be similar to RVP. And the pacing parameters are comparable with RVP. However, the pace, the car's duration with LBBAP was significantly shorter than RVP. And this year, another study also compared the learning curve between LBBAP and HBP. That means they conclude that the procedure duration and the fluoroscopy time are both lower in LBBAP when compared with HBP. So, based on the features of LBBAP and the better pacing parameters, now the LBBAP has been a feasible and the first choice of cardiac physiological pacing firm in clinical practice, especially in China. I think in China, lots of centers has practiced the LBBAP in clinical practice in routine works. Second, let's see the impact of LBBAP on ventricular synchrony and the improvement of left ventricular ejection fraction in patients with reduced LVEF. Uh, 4 years ago, our team first evaluated the impact of LBBAP on LV synchrony by using echo, and we found LBBAP could maintain the LV synchrony in patients with narrow CARS. And for patients with complete left bundle branch block, and the LBBAP could improve the LV synchrony. However, this study was the first study of LBBAP in patients with AV block. I think at that time, maybe the LBBAP is just the LVSP. Now, with the practice, I think if the and also in our study and in the clinical practice, we found if we performed the successful LBBP, and the LV synchrony will be improved more. In this study, we investigate the correction rate of bundle branch block, including left bundle branch block and right bundle branch block. We can see the the LBBAP could correct left bundle branch block, also right bundle branch block. Here we show another the echocardiography evaluation of the LV synchrony by LBBAP. You can see the narrow CARS right bundle branch block and the LV block, LBBP. Professor Zhou, their team first evaluate the LV mechanical synchrony by SPAT. They compared the effect of LBBP and HBP and RVP in patients with LBBP. Also, here this study is at the initial stage of our we perform the LBBAP. So at that time, some patients will have the left bundle potential, and some patients with LBBP without the left bundle potential. So they found patients with LBBP and left bundle potential, the LV synchrony was comparable between LBBP and HBP. I think this study is very important. They provide the evidence that LBBP could maintain and maintains the LV synchrony like the HBP. Our team also studied the impact of LBBAP for patients with heart failure. This study was published at 2020. At that time, we are just observed the impact of LBBAP, and we found the success rate is a little bit low. Now maybe the success rate will be high in patients with heart failure. Patients with heart failure have the enlarged left ventricle, and the procedure might be challenged. And we also compare the patients with successful LBBAP and BIVP by using the principal score matching method. And we found the patients with LBBAP have a high super response than patients with BIVP. Here's the changes from 6 months to baseline between two groups. And also we use in the multivariate factor regression analysis to show that the LBAP was an independent predictor for super response and clinical response. This study was published last year, and Professor Zhou and our two teams conducted this first prospective randomized controlled trial. And in this trial, we compared the difference in left ventricular ejection fraction improvement between LBBP and BIVP. And we found the LBBP CRT code significantly improves higher left ventricular ejection fraction compared with BIVP. And for other parameters like the LV, ESV, and the BNP, NT per BNP, also LBBP have had resulting better results. Finally, let's see the impact of LBBAP on avoidance or mitigation of heart failure in patients with normal left ventricular ejection fraction. Not normal, just including some patients with moderate reduced left ventricular ejection fraction. In this paper, that's the International LBBAP Collaborator Study Group. They summarized more than 300 patients with LVF less than 50% and indications for CRT or pacing attempted LBBAP, and they have a success rate of 85%. And the mean follow-up of 6 months. And in this paper, they found for patients with moderate to reduced left ventricular ejection fraction, and the LBBAP could improve the LVF from 41% to 52%. Yeah, this study is from Professor Huang. They studied the LBBP in patients with PICM, pacing-induced cardiomyopathy, and the follow-up duration of 1 year. And they found the LVEF could increase significantly from almost about 36% to 51%. And this study studied the patients with high burden RVP, high burden of VP%, I think. And from this study, the patients with RVP and LBBAP was compared. This large sample, and they found LBBAP could result in improved clinical outcomes, include the all-cause mortality and the heart failure hospitalization. The primary endpoint was the composite of all-cause mortality and heart failure rehospitalization. And this result is more significant in patients with a VP% more than 20%. This study is from our team, and we also compared the patients with in patients with AV block we performed this prospective observational study in 5 centers, and we compared the patients with LBBAP and RVP. We can see in this paper, we found the LBBAP, the success rate is significant, not significant, is high than our study in 2019. So the success rate of LBBAP now I think is commonly higher than 95% in most centers. And in our study, we found the patients in patients with RVP, the clinical outcomes of heart failure, hospitalization, and upgrade to BiVP was significantly higher in patients with RVP than patients with LBBAP. So we think in patients with a high burden of VP percent, the LBBAP could reduce the risk of heart failure hospitalization or upgrade to biventricular pacing. Here's another study published in Europe this year. They also prospectively observed the the burden of the occurrence, the incidence of atrial fibrillation, and the incidence of atrial fibrillation in patients with LBBAP is significantly lower than in patients with RVP. And this study is also from our team, and I think this study is very important because we include all patients without history of atrial fibrillation, and our study showed that the LBBAP could significantly reduce the risk of new onset atrial fibrillation compared with RVP. That also means even the patients without heart failure and the RVP could increase the risk of atrial fibrillation, and the LBBAP could reduce the risk of atrial fibrillation. Here is another study. Our team investigates the impact of LBBAP on the echo parameters and the clinical outcomes in patients with chronic atrial fibrillation. These patients in clinical practice, they requiring ventricular pacing, and some patients underwent the LBBAP, and another group underwent the RVP. And during almost 1 year follow-up, we found the primary outcome was comparable because these patients and most of these patients have the LVEF is over than 35%. So the endpoint is less, and so the primary outcome was comparable. However, when we focus on the echo parameters, we found LBBAP could significantly reduce the left atrial diameters. Oh, sorry. So let's see this year's the guideline recommend that in patients with ejection fraction less than 35%, the LBBAP might be is reasonable if CRT, that means BIVP, cannot be achieved. And for patients with moderate reduced LVF, the LBBP could be considered. I think in routine practice, we can choose devices in patients with heart failure after this evidence. For patients with moderate reduced LVF, maybe the DDD device could be choose. And for patients with chronic atrial fibrillation, the the VVI, the single chamber device could be achieved if the LBBP could be successfully implanted. And for patients with atrial fibrillation and heart failure, I think later the Professor Huang will be introduced. And these patients, maybe we have more choice when we have the LBBAP. So I like summary my topic. I think the technique and the pacing parameters make a high possibility of LBBAP in clinical practice. And the LBBAP have demonstrated beneficial clinical outcomes and the impact of LV synchrony in patients. So LBBAP should be performed in patients with high VP% to avoid future heart failure. And LBBAP could be alternative to BIVP for mitigation of heart failure according to current clinical evidence. Thank you.